Good afternoon. This is David McDonough, neuroanesthesiology editor at openanesthesia.org. On behalf of IARS and A&A, I thank you for listening and extend a warm welcome to Dr. Joshua Bell. Dr. Bell is a PGY3 resident in the Clinician Investigator program at the University of Toronto. He's currently at Stanford University doing a neuroprotection research fellowship. In the April 2017 issue of A&A, he published a review article titled, In Vogue, Ketamine for Neuroprotection in Acute Neurologic Injury. This is a timely topic in neuroanesthesia and neurocritical care as we see a resurgence in ketamine use in the operating rooms and ICUs. And I congratulate Dr. Bell on being chosen as the article of the month and for his successful publication of this manuscript. Welcome, Dr. Bell.
Oh, thanks, Dr. McDonough. It's nice to be here, and thanks for the opportunity to chat about this.
To get started, can you tell us how you got interested in ketamine pharmacology?
Sure. So my interest in ketamine sort of was born out of the postgraduate research work that I did prior to going to medical school. I actually did a PhD in neurobiology, and my focus was glutamate receptor physiology and sort of how glutamate receptors traffic to and from the membrane and how the phenotype of various glutamate receptors changes after trauma and stroke. And when I sort of started my anesthesia training, I learned about ketamine and how ketamine works and the fact that it's an NMDA receptor antagonist, and I did some more sort of digging into its specificity for various NMDA receptor subtypes and sort of approached a couple of people and said, you know, has anybody ever tried this drug in any of the neurologic conditions that involve neurodegeneration secondary to glutamate receptor stimulation and excitotoxicity? And you know, people sort of didn't really know. They knew about ketamine in the context of analgesia, but nobody had really looked at it in neurologic injury. So that sort of prompted my interest in the whole field of ketamine for neuroprotection. And I worked in a lot of labs that focused on excitotoxicity and various different NMDA receptor antagonists and their role in preclinical modeling of stroke. And you know, there was just so much literature that it was such a dominant process in neurodegeneration throughout so many different conditions, and that's sort of why I found ketamine so compelling pharmacologically, because of its mechanisms of action.
Along those lines, can you give us an overview of ketamine's mechanism of action in terms of excitotoxicity, neuroinflammation, and neuronal hyperexcitability?
Sure. So actually, a lot of that work comes out of Toronto, where I did my PhD, and actually two of the people who characterized a lot of that were actually on my PhD committee. So I've sort of had the privilege of working closely with a lot of the scientists that pioneered this stuff, one of whom is actually Dr. Bev Orser, who I'm sure you know well. And she and some other people showed a long time ago that ketamine is obviously, it's an anti-NMDA receptor drug. It's an NMDA receptor antagonist, and it works in two ways. It blocks glutamate induced currents through NMDA receptors in two ways. It's got an open block and a closed block. Basically what that means is that when glutamate binds to the NMDA receptor, ketamine reduces the amplitude of currents going through the NMDA receptor, and then that's called an open block. And then a closed block is when the channel is closed, it reduces the frequency of the channel opening when glutamate binds. So it sort of works in those two different ways. And excitotoxicity is, for any listeners who aren't familiar with that term, it's essentially that's neuronal cell death that occurs secondary to excessive stimulation of glutamate receptors, particularly the NMDA receptor. And the reason this occurs in stroke and in trauma is basically when you have an ischemic neuron, you have an electrogenic sodium-potassium exchanger, and when blood flow fails and when ATP delivery to a neuron fails, the sodium-potassium exchanger also fails because it's powered by ATP. And so what happens is you have a large accumulation of sodium, you have neurons that depolarize, and you have uncontrolled fusion of glutamatergic vesicles with the presynaptic membrane, and that glutamate spills out into the synapse. And as a result of spilling out into the synapse, it binds to postsynaptic glutamate receptors, which then depolarize, and it's a cascade sort of going from one neuron to the other, where you have this uncontrolled depolarization and uncontrolled calcium influx through glutamate receptors. And it's interesting because we used to think that glutamate binding to any glutamate receptors was toxic, and we've learned over the years that that's actually not the case, that glutamate is selectively neurotoxic with specific NMDA receptors, particularly a subtype of the NMDA receptor called NR2B containing NMDA receptors. And so Ketamine works for excitotoxicity because it's an anti-NMDA receptor drug. It's an NMDA receptor blocker, but it also has some selectivity for NR2B containing NMDA receptors. And those are really neurotoxic because they have protein-protein scaffolds. So the NR2B subunit binds intracellularly to other pro-death proteins. And so that's why the calcium coming from NR2B containing receptors is so toxic, is it's in such close proximity to some of these pro-death proteins, one of which, for example, is neuronal nitric oxide synthase. And so you get tons of generation of nitric oxide secondary to NR2B activation. And so the nitric oxide then binds to other free radicals, superoxide and peroxynitrite is generated, and you get all of these reactive oxygen species that are generated, and lots of downstream DNA fragmentation and apoptosis and breakdown of the cytoskeleton. So ketamine antagonizes a lot of these effects because it blocks NR2B containing receptors. But it also has another interesting mechanism, which some people don't know about, this postsynaptic mechanism of action, as we just discussed, but then it's also got a presynaptic mechanism of action, which is that ketamine has the ability to interfere with a snare complex formation. And the snare complex is a group of proteins that anchor glutamatergic vesicles to the presynaptic membrane. And so in addition to blocking postsynaptic NMDA receptors, it also prevents glutamate release presynaptically. And so you get this sort of two-pronged effect. And this has been shown in cell culture models and patch clamp models, where you can look directly at the quanta of vesicles that fuse and how much glutamate is released into the synapse, as well as the postsynaptic currents.
What's ketamine's role in neuroinflammation?
I'm glad you asked, because it's sort of an emerging area in ketamine physiology. I don't think a lot of people knew that ketamine was an anti-inflammatory sort of 5-10 years ago, but now we're learning that ketamine, in addition to being an anti-NMDA drug, it's also an anti-inflammatory, primarily in CNS immune cells and in microglial cells. Microglia are sort of the resident immune cells of the brain, and there's been a handful of really good studies demonstrating that in response to inflammatory stimuli like lipopolysaccharide, glial cells and microglial cells reduce the release of a lot of pro-inflammatory cytokines, including tumor necrosis factor alpha, interleukin 6, interleukin 8, and there's a neuroinflammatory response to hypoxia that's also blunted by ketamine. And I guess we'll get into this a little bit later on, but a lot of the data coming out showing the efficacy of ketamine in things like POCD and cardiac bypass for neuroprotection, a lot of that data suggests that the mechanism is actually an anti-inflammatory mechanism as opposed to an anti-excitotoxic mechanism. The other thing I should mention from an anti-inflammatory standpoint is that there's these emerging damage-associated molecular proteins, one of which is high mobility group box 1, that's HMGB1, that's sort of the prototype DAMP, as we call them. And there's some data coming out now that shows that ketamine can inhibit HMGB1 release from inflammatory cells. And we know that HMGB1 plays a critical role in neuroinflammation. It predicts high levels of CSF. HMGB1 predict non-survivors in subarachnoid hemorrhage. We just published an investigation in neurocritical care showing that elevated HMGB1 is involved in delayed cerebral ischemia after SAH. And so we don't know exactly which of these anti-inflammatories is so critical to neurodegeneration, but the nice thing is that ketamine appears to have sort of a broad anti-inflammatory effect. And probably that anti-inflammatory effect plays a big role in its analgesic effects as well, because it also reduces a lot of these cytokines from being released in peripheral immune cells.
So we all know that there's no high-level evidence currently for ketamine as a human neuroprotectant, but tell us where does the field stand in terms of moving toward some proof that ketamine offers neuroprotection in various forms of clinical brain and spinal cord injury?
So I think one of the reasons that there's a sort of a paucity of human data is that there was this overarching assumption that ketamine increased intracranial pressure in TBI patients and in subarachnoid hemorrhage patients. So everyone sort of shied away from it in neurocritical care and in the treatment, the acute treatment, for example, craniotomies and traumatic brain injury patients. But I think it's important sort of right from the outset to say that this has essentially been completely debunked, that the raised ICP effects of ketamine in clinical neurotrauma were actually far more related to hypercarbia and patients being allowed to breathe spontaneously during ketamine administration. When controlled ventilation is initiated and normal carbia is maintained, the ICP effects of ketamine are basically completely blunted. And there's a number of review papers that have looked at this and shown that it doesn't increase ICP. So having said that, there are a couple of investigations that have looked at the clinical efficacy of ketamine, probably one of the most compelling ones is a study that showed that across a number of neurologic disease states, TBI, subarachnoid hemorrhage, and malignant stroke, there's this phenomenon of spreading depolarizations. And spreading depolarizations are bad for a number of reasons. They're a state of neuronal hyperexcitability that obviously worsen excitotoxicity and calcium influx, but they're also bad because they worsen flow metabolism, coupling essentially hypermetabolic groups of neurons don't get adequate perfusion, they become ischemic, and spreading depolarization is basically like a seizure that just kind of spreads uncontrollably throughout the brain. There was an investigation that looked, it was retrospective, but they looked at the ability of a number of sedatives and analgesics in the intensive care unit, and they published it in Brain a couple of years ago, and they found that ketamine of all of those drugs, sufentanil, morphine, propofol, midazolam, etc., was actually the one drug that reduced the incidence across conditions of spreading depolarizations, which was really, I think, probably the most compelling evidence we have so far. But as I said, there's also the other emerging evidence is in the field of POCD. So there's a couple of investigators who've looked at boluses of ketamine at the induction of cardiac surgery and shown that it reduced the incidence of POCD. And as I said, they think that this is through inhibition of C-reactive protein, IL-6, IL-10, these types of things, as opposed to excitotoxic protection. And then the other area that it's now emerging, as I'm sure you're aware, is in refractory status in the neuro-ICU. There have been a number of, as I said, again, retrospective analyses looking at patients with refractory status, and ketamine in refractory status is actually sort of now thought to be more effective than the GABAergic anticonvulsants, because some very smart people figured out that as a seizure gets prolonged, the molecular mechanisms of why it's occurring actually change. So when you initially have a seizure, it's due to a paucity of GABAergic conduction. So you use GABAergic drugs like midazolam to increase the amount of GABA in neural inhibition. But as seizures get prolonged, what happens is there's actually a molecular switch where the hyperexcitability is perpetuated by NMDA receptor activation. And so that's why when you switch to an NMDA receptor antagonist, you have better efficacy in controlling refractory status. And so those are probably the two most compelling paradigms clinically that have shown efficacy for ketamine. The other thing I should mention is that there are a number of studies that are ongoing, one including ketamine with TPA for thrombolysis and acute ischemic stroke. There's a study in France doing that right now. And we are working on a study as well using ketamine in subarachnoid hemorrhage. I don't know if you want me to talk about that now or...
Yeah, why don't we wrap up with that? Tell us where you're going with ketamine in your own research.
Yeah, so we're doing a study right now. It's called the KIND trial. It stands for ketamine infusion in neurologic deficit, and it's a study where we have patients who come into the neuro ICU with subarachnoid hemorrhage. They're randomized to either ketamine or placebo treatment should they have an episode of delayed cerebral ischemia. So if they meet criteria in the neuro ICU for lack of a better word, what's called vasospasm, then they will get randomly assigned to either ketamine infusion or placebo infusion. And then our follow-up is, and I should mention, these are at analgesic doses, so they're low doses, where our study is at 5 mics per kilo per minute, which in a 70 kilogram male, that translates to about 20 milligrams an hour. And our follow-up with those patients is 3 Tesla MRI. We're looking at CSF and plasma biomarkers of neuroinflammation and of neuroinjury. We have a validated panel of neuroinjury biomarkers and neurocognitive follow-up. And for the patients who have EVDs, we can get some pretty good data from what's going on in their CSF during delayed ischemia, but even patients who don't have EVDs are included. And so we're not the only people doing this. There's some other people who are interested in ketamine in SAH as well around the world. There seems to be a lot of work coming out of France. I'm not sure why, but they seem to be very interested in ketamine physiology, especially for POCD. There's also a number of investigations ongoing with this bolus of 0.5 milligram per kilogram at the outset for POCD. At the outset of anesthesia, I should say, on induction.
Well, I think your review article is going to generate a lot of interest in the anesthesiology community, and we thank you for sharing some time with us and insights with us today. Best wishes as your career develops, and thanks again.
No problem. Thanks for having me. I really appreciate it.